So I think we have a few minutes for Q&A. So why don't we go ahead and start, Henry? Dr. Chen, why don't you introduce yourself to
Henry Chen.
It needs no introduction.
I'm from Hong Kong and
Yes.
a past president of the societies. I want to ask the first three speakers, wonderful job, but at the same time, these works have been published many years ago. When David Seaton published in Lancet 2003 on the use of pulsar lasers, and many others have since published. But the use of pulsar laser never take off. I love you, Ariel, but we need to start thinking up, a bit more excitement here. And monopolar radio frequency, same thing. Published in Dermatology 2003. Nothing ever happened. I mean, in many ways, the market determined if certain device will survive, and it never take off. 1064, okay. Both 1064 monopolar radio frequency are not very selective. It just hit up everything. So is this just a kind of temporary improvement with a very, very expensive cost? Or are we really getting to a more, long-term cure? So please, really, do we want to justify to ask our patient to spend all this money doing things that is not really working? Thank you very much.
Any comments about that?
I think that that's a great point, Dr. Chan. I think that these treatments are treating, they are not curing acne. But for some patients where they don't want to be on oral antibiotics, they don't want to take Accutane, and certain things they don't want to do, I think it's nice to have some options that are available for them. This isn't for everyone. It's not replacing traditional medical therapy, but it's just something else to add. And then for our study, we actually have some patients that we followed for 6 months who are not on topicals, and they're still doing great. So there's something there.
Dr. Kavar?
Yeah, so in terms of my study population, for many, many years now, probably over 25, I've been treating adult women with continued inflammatory acne with pulse dye laser. And typically 3-4 monthly treatments, and they go into remission, sometimes for years. And they don't have to use topicals or, all of these extensive regimens twice a day and oral antibiotics or low-dose oral antibiotics. And so for most adult women, this was a great option. And the reason we went to try to explore this for the wider population of adult female inflammatory acne was because of my experience with those individuals. And it's not uncommon for individuals switching hormonal therapies to have this cystic flare. And it really melted away their acne. So the question was, could this approach be used? Now, this is different from the very original pulse dye laser publication. We use very, very low energy. We're using sort of standard fluences here. And what we did in this study was do 3 passes to the entire face with a traditional energy fluences, so 10 millimeters, 10 milliseconds, 6 joules per centimeter square, and then another 2 passes at higher fluence over the individual lesions. So this wasn't comparable to the paper that you mentioned.
Ariel, I love you too. I use pulse dye laser all the time using the parameters that you mentioned for rejuvenation, so on, so on, so on. I mean, yes, some patients have some improvement but reactive acne is something that I do see fairly often. And the long-term remissions, with all respect, we are similar age, so that's why I just asked you 3, not the other 4, okay? I'm 20, for 20-odd years too, I've been doing this, and I do not see the same observation that you have. Once again, maybe different experience, but just to share with the crowd. Thank you.
Yeah, I guess just one quick comment, but listening to all of these, is, most of the things in dermatology that we treat are chronic anyway. So 90% of everything that we treat in dermatology are chronic. So there's really no cure for most of the things that we treat anyway. So it's basically just a temporary, resolving the solution. So I think, it's just another tool in addition to everything else that we have. Go ahead.
Thank you all the speakers, the wonderful talks. I have one question for Nazanin and one for Ariel. Nazanin, did you use any type of anesthesia, topical or otherwise? And Ariel, I know you treated acne inflammatory acne with PDL, which we all do. Do you treat erythematous acne scars with pulse diet too?
So for your question, we didn't use any anesthesia for it.
For the question about whether we treat erythematous scars, yes. And there was a patient, before and after that, I showed a patient with phototype 4 skin and the post-inflammatory pigment erythema, post-inflammatory erythema and pigmentation resolved with the 4 pulse dye laser treatments.
Yes, go ahead. You can introduce yourself.
Oh, Tina Schaffer from the Twin Cities in Minnesota.
Okay, thank you.
Just one other question. You already answered a little bit, 3 passes. You did your first one full face. When you were doing individual acne lesions, and this is for the pulse dye laser, are you looking for a certain clinical endpoint, or what do you mean by higher energy on that when you're just spot treating at the end?
So we actually did 2 to 3 passes depending on the coverage of the entire face at 10 millimeters, 10 milliseconds, 10 millimeters, 6 milliseconds, 6 joules per centimeter square. And then over another 2 passes, like pulse stacking over the individual lesions with 10 millimeters, 6 milliseconds, and 7 to 8 joules per centimeter squared, depending on the phototype. So the lower range on lighter phototype, on darker phototype, and the higher range on lighter phototype skin.
Thank you. Yes, please go ahead. You can introduce yourself too.
Hi, I'm Monica, one of the second-year PGY3 dermatology residents at Georgetown. Thank you all so much for your very wonderful presentations. I had specific questions for Dr. Humphrey and Dr. Shipman. I thought they were very synergistic presentations. So Dr. Shipman, as he pointed out, we do know that laser hair removal does work for treatments and even perhaps disease progression in hidradenitis suppurativa. Dr. Humphrey, I thought it was very interesting that you presented your case with the vulvar acne keloidalus. What was your experience, as Dr. Shipman pointed out, insurance coverage is generally an issue for these sorts of treatments. What's been your experience with getting insurance coverage for your patients?
Yeah, sure, absolutely. Thank you for the question. So we have a fabulous team of staff at the front office who are excellent with prior authorizations. So oftentimes when a patient comes in with a medical comorbidity, we're able to not only get it cleared through insurance for treatment in the office, but also in the operating room if it is necessary and it's within appropriate.
Any comment? Did you want to comment, actually?
Yeah, I would just agree with Dr. Humphrey and say, it is challenging, but I do think at Yale we have a great staff. Oftentimes it's denied and then we appeal, and then we have success in many of our patients on the appeal.
And I think just a quick comment, I guess, regarding hidradenitis. I don't think you can go to any dermatology meeting right now and don't hear about HS. I mean, it's amazing how much there has been such an interest on HS all of a sudden. Obviously, there's a lot of JAK inhibitors and lots of biologic drugs that are treating the HS also, hidradenitis suppurativa. So I'd be interested to see, I mean, we're talking about, I guess, lasers, but those drugs are even much more expensive to in terms of administration and dealing with the patient. So another interesting thing, and maybe that could be in conjunction with the lasers, using those drugs plus the
absolutely.
lasers.
I love the point that Dr. Shipman made in his presentation about really if you compare the cost of the biologic, like if you're thinking like Cosentyx or Humira or whatever you choose to use in comparison with the cost of laser treatment, it's, night and day.
Exactly. Go ahead.
So I'm Maggie. I'm one of the second-year resident at UMass. Great talks and presentation. Dr. Shipman, for the HS, the 2019 guidelines published in the JAD was stating that whatever settings good for laser removal is good for HS patients. Do you still think that we can do alexandrite for fair skin complexion patient with HS, or do you think that Nd:YAG will be a better option for all HS patients, regardless the complexion?
So that's a really great question. I think, it comes down to a discussion about risk of dyspigmentation with the patient. So, I think alexandrite laser is a great laser for laser hair removal, but it does come with a greater risk of dyspigmentation. But you have to balance that with the already apparent risk of dyspigmentation that HS disease itself is going to cause the patient, right? So We would recommend probably using the Nd:YAG laser for a patient that's Fitzpatrick skin type 5 or 6, or maybe even 4 to 6, right? Because that's going to be less risk of dyspigmentation for that patient. But if you're in a practice location and you only have Alexandrite laser and you have an HS patient that is skin type 5 and 6 and they have really bad disease in their armpits or axillae and they really want laser hair removal, that patient may be okay with getting dyspigmentation in their armpits, and they may say, hey, they're already discolored, they're already dyspigmented. I don't care about the dyspigmentation, just get rid of the hair if it's going to help me. And that's kind of like a conversation that you would have with that patient, and they may be fine with getting the Alexandrite.
But if you have a skin complexion 1 and 2 with HS, would you use Alexandrite or Nd:YAG?
So I think the Alexandrite would be fine with that patient. I think the only benefit of the Nd:YAG in that instance would be, the risk of dyspigmentation. But I think the Alexandrite laser is still a really good laser for laser hair removal, and that was included in a lot of our studies. So the Alexandrite laser has been shown to be just as effective in HS in our studies.
Thank you so much.
I agree with Dr. Ahmed's comment. I think probably, the shorter pulse are probably more effective with laser hair removal anyway, and they're less painful. So in that case, you have probably a better option for a skin person. Dr. Sakamoto?
Fernanda Sakamoto from Boston. Just going to ask a question for Dr. Humphrey and Sandy. Did you take the patient to the OR for laser hair removal?
Yes, ma'am, we did.
Could you justify that, please?
Just because, so the patient does have a pre-existing, her comorbidity, so she has autism spectrum disorder as well as anxiety. So, when you're thinking about acne keloidalis in just anybody, one, if you inject with IL steroids, it's going to be painful. Now, if you're talking about in such a sensitive area, and a patient with autism spectrum disorder who doesn't really tolerate the physical exam in the beginning, that's why we pushed for the OR, and that's why we ended up getting clearance per insurance.
Now I understand the case.
She actually would not allow anybody to touch her. So we think that the whole process evolved as a folliculitis due to that. And so in order to actually do the treatment and even actually get an exam and biopsy, we had to do it in the OR. So we were very fortunate that they did cover it, but with a knowledge, with a lot of backup clinical data showing that, this was obviously an ongoing enlarging process and could not be done in the office. Mm-hmm. Yeah.
Thank you very much, everybody. Thank you to all the panel and fantastic talks and fantastic comments from the audience.